for the last session of this training. We've enjoyed conducting this for this whole week and hope the same is with all of you. Today, of course, we are going to be talking about a very, very important part of the training, which is important for all of us, including our patients and their families. Through this week, we've been through the journey with Ramesh and his family through the complex the situation of COVID, the isolation, the quarantine, his death, his difficult symptoms, as well as grief and bereavement. And today, of course, we're going to look at a very important topic, which is going to be taken by Smriti. I think none of you need an introduction for Smriti Rana, but I still have great pleasure in letting you know she's the program director of PalliCovid India, and she's worked with PalliCovid India since 2012. She has a keen interest, especially for providing palliative care services during humanitarian crisis like this COVID-19 crisis. And she's going to be talking about this very important topic of distress, and ably supported by Dr. Charu as well as Dr. Dinesh. To introduce you to Dr. Charu, she's a very senior palliative care physician and initially trained to be an anesthesiologist and an intensive care specialist, and who's worked in Kerala for many years and now moved her base to the north to Faridabad. And Dr. Dinesh Kumar, who's actually trained in community medicine and works in Anand, Gujarat. Both of them will be supporting Smriti for this interesting conversation, discussion. And please keep the chat box busy. And I'll take this opportunity to say bye to all of you and hope to see you in person at some point and stage in life. And good luck, stay safe and stay well, all of you, because Smriti will be doing the wrap up. I might not see you at the end. So over to you, Smriti. The session is also being attended, and so Dr. Chitra, who's had a valuable input in making these presentations, is also there. Also, Dr. Rajeshri is around, so there's enough people to handle all your questions, so keep them rolling. See you all. Thank you so much for coming. Over to you, Smriti.
Thank you, Rajam. Thank you so much. And hello, everybody, and welcome to our fifth and final session. And I'm really honored to be taking it. I'll be using the slide deck that Dr. Chitra put together, and we've had a lot of discussion about it, and I'm really looking forward to an interactive session. Before we get into it, I'd like to just acknowledge the fact that all of you are here right now in the middle of your work day at the end of a probably challenging week, and everybody works in different kinds of settings. Some of you are seeing COVID-19 patients, some of you are seeing extremely people with advanced illnesses, some of you are seeing other difficulties. And I'm sure you're also trying to manage your work and your personal life and all of this. So I'm going to take a moment to ask all of you I'm going to give you a prompt, and I want you to think about how this sentence ends for you. So the prompt is, I wish someone would ask me ... So what is it that you wish people would ask you right now about where you are, how you're feeling? So yes, someone, Sonali, has said, what I am truly concerned about. And you don't have to share it on the chat screen. This is just something for you to think about. What is it that you really want people to ask you right now? I wish people would ask me. And what I'm pointing at through that is that there's a lot of distress around, including within us. And what you're asking people to ask you is something that you are asking yourself as well. It's acknowledging that own part of you that you wish others would see. So today we're going to be talking about distress and making sense of distress. And when we talk about distress, we're going to be talking about distress of the patient, the family, and very importantly, the healthcare provider. So I'm just going to share my screen now. Charu, is this visible?
Yes, it is.
Okay, good. Okay, so this whole slide deck was put together by Dr. Chitra Venkateswaran, who is a psychiatrist and a palliative care physician, and someone that I have had the privilege of learning a lot from. And so I'm going to be using her slide decks with some of my inputs and with the help of my co-facilitators. Chitra is also here, so I'll be calling on her to make some comments from time to time. The learning objectives of today's session is we hope to understand the relevance of psychosocial issues in the COVID-19 setting, and there is evidence that we're going to be referring back to. We learn to identify and assess emotional distress, and also focus on some particular issues that we are most likely to come across in our settings. We will also learn to use the algorithm in the ebook. So I'll be asking Dr. Chitra to take us through it very quickly and just help us learn how to navigate it. And we will also pay close attention to spiritual distress and its management, because that is a part that very often gets relegated.
I've lost Smriti.
Yes, ma'am. I think connection lost.
While when Smriti is trying to get back, I just summarize like whatever chats have come up.
Yeah.
So most of the people would like someone to ask them how they feel, someone who can express their concern for them, or someone who can just sit beside them without any specific things to express. If someone can just sit beside them, probably that will be the best thing for them.
And this just reminds a statement to me, which I, of course, got on from the University of WhatsApp, that a true friend, when things get tough, a true friend pours coffee, pulls up a chair, and sits down next to you. So I relate to Dr. Jitesh when he says that I wish someone would just sit beside me.
I think it's especially relevant when people are feeling so isolated and disconnected, isn't it? That if someone just sits beside you for a few minutes, Jitesh, that is a very good point. That you need, we outwardly don't express such, wishes, but all of us would love to have someone near us to offer, or to be, the presence of a person beside us is so very important. I think Smriti has joined.
Smriti, are you back?
Smriti ma'am, can you hear us? Smriti ma'am?
Do you have a presentation, Arun?
I'm just looking at it because I think Smriti, no, she had just shared her screen, so we don't have a presentation.
Yes, ma'am. We don't have the presentation.
But I do have the other presentation for the.
Let me just find out from Smriti.
Saru,
can you find
this kind of?
Can you find out your PPT?
Anyways, shall we? We'll wait for Smriti to join us, but I don't think we have too much of time here. So, Dr. Chitra, would you chip in, or?
Do you have the PowerPoint to share?
Smriti, just give me a call. Smriti? Smriti? I'm here.
Can you share the presentation? Whatever you have.
So what I suggest is, Charu and Chitra, why don't you talk to each other and sort that out, and I can start talking to the group. How's that?
Just talk. I'm just trying to get the PowerPoint, Moira.
Okay, so sorry for joining late. Greetings to you all. I think today is a really important session because this issue of distress and how we manage distress, how we understand it, is really important. I wonder if people could, maybe you've been sharing already, I'm sorry I came in a little late, but are there any things that you would like to start sharing about how you are seeing distress at the moment? So it can be from anyone, any situation. Just tell me examples of distress that you are seeing during this COVID time with your patients. Or with yourselves. Please just start to write them down for us. Worries and anger.
Worries and
Thank
anger.
you. Thank you. Worries and anger. And of course, we know that anger can come out of worry. I think it's nice you put those two things together, because when we're worried, actually it can be expressed as anger, but behind that anger is often worry and distress. Helplessness. Helplessness, for whom do you think, Vani? Can you tell me, Dr. Vani, lovely to see you from Mizoram. Who's feeling helpless, do you think, in these scenarios? I think it's a very powerful emotion, helplessness. And Roger, thank you. You're talking about anxiety. Wow, hopelessness. So hopelessness is that feeling that there is nothing to be done. And hopelessness can lead to despair and actually can be a sign of something very difficult. We know that if we can find some meaning, even in the midst of the most difficult times, it can somehow make it easier to manage. So helplessness can, let me see what else you put. Yeah, so there's a lot of this, isn't there? You hear someone's positive and then everybody around about them has 2 weeks of, am I also going to get affected? Did I do something to cause this? Behavior change. Give me an example of behavior change. I would love to know. I've heard there's some here, something about losing sleep and irritation. That's behavior change. Any other behavior changes? Dr. Tasneem, thank you. Conflict issues between healthcare staff. You see, when we're feeling helpless and when we have so much distress around us, you know, sometimes we can manage the patient and the family interactions, but we struggle with the interaction with one another because we're all tired, we're all exhausted, we've kind of run out of energy, and then we can get into conflict. Are you able to share with us any, I don't mean personal examples, but any sorts of things that are causing conflict? That would be very helpful. What sort of things are causing conflict?
Sorry, Arun, is it possible for you to allow me to share my screen, because Smriti has sent the slides to me.
Okay. Ma'am, actually, Charima, you got the slides? No?
Yes, Smriti has sent them to me
okay,
via mail.
Ma'am, it's already enabled. You can share the slide. If you have any problem with sharing slide, otherwise I can share the slide because I got the slide in inbox. Okay, ma'am, you can start sharing. No issues.
Okay, and I think Moira and
Charu, yes, you carry on and share. Then I'll just, while you're doing that, I'll just summarize for you, Charu, if that's okay.
Yeah.
The group have just been listing the things that they're seeing in terms of distress, and they've listed so many helpful things: worries, anger, helplessness, hopelessness, fear, anxiety, behavior change, sleep loss, irritation. They're talking about conflict between staff members, that feeling of helplessness. They've expanded to say it's you're not able to help the patients or help the wider society, so you're feeling helpless as a doctor or as a clinician in the face of this pandemic. So they're really, really useful ideas people have, which are going to just lead into your talk, Charu, I know.
Absolutely. I'm very impressed with the number of aspects of distress, or different versions of distress, or maybe the components of distress that people have put across in the chat box. And we're just going to try and make it, bring some more meaning to it, both for all three of us, for Ramesh's family and especially the healthcare providers, because we tend to overlook our needs also sometimes. So I think Smriti had covered the learning objectives, and we were going into the clinical narrative of Ramesh.
Just share. You have not shared yet.
Charima, please
thank you for letting me. Yeah,
And while you're sharing, there's also some other ideas coming here about suicidal ideation and depression. Thank you for that. And also you've told me, I asked what the conflicts were. You said conflicts with duty roster, quarantine and isolation, how you're doing around shift change. That is tricky actually. And then you brought up, Raji, thank you for bringing up the issue about children. So there's distress for families, distress for children, particularly students who are missing out on education. And they're also feeling a bit trapped as well, I think. Wonderful. Charo, over to you.
Can you see it now?
Yeah.
Okay. So yes, so Smriti had covered the learning objectives, and I'm glad that you have all put down what distress means to you, or what you have been experiencing, especially those who have been looking after COVID-19 patients. So these last 4 days, we have been sharing Ramesh's life. And yesterday, Ramesh passed away, and we are taking a look back on his journey of what he went through at different aspects, at different points, what his family felt through the whole process, and how did it affect the healthcare providers. So at one point, he was clearly anxious, unsettled. And he used to keep, we do know isolation, quarantine, you can't see your family. Family members have this feeling of being tearful and being separate from their loved one and not knowing whether they'll ever see him alive again. And we are dealing with a huge number of patients and trying to juggle our shifts and our roles and responsibilities. Most of us are multitasking here. For some reason, I have a different thing for slide changer.
Can you put it into slideshow?
I am not able to do that through my...
No, it's
Chat.
a PDF, so you won't be able to. So maybe just carry on, Chitra, and then Charu, and then one of us can look for the PowerPoint. You haven't got the PowerPoint. Chitra, can we sort that out between us?
Ma'am, otherwise I can share the slide from my side, and you endorse the slide, you can say next, then I will change the slide.
Perfect, Dr.
That
Dinesh.
should be fine.
Ma'am, can you stop slide sharing?
Yeah, give me a second. All right.
Hello, Charu ma'am.
Yeah. So I think this is better. I will just ask Arun to change the slides for me. Thank you so much.
Okay, ma'am, please say next at the end of the slide. Okay.
Yes,
then
I will. Of course, I will.
But thank you.
So I'm repeating myself again. We've had different definitions of distress coming up, and we've also seen what Ramesh, their family, and the healthcare providers have gone through. But who is the most at risk for developing this distress? Where is distress felt? Can anyone put in the chat box? Where do you feel the distress? It's in your mind. I actually tried to look up the Hindi meaning of distress, and it said pida. So takleef. So distress is felt, yes, it is cognitive, physical, at emotional level. And
Felt in mind, apparently.
yeah, but distress is, yes, meant in mind. There can be many reasons for this distress, as someone had put across, and the manifestations of distress can also be in this four realms. So who are the people who we are at high risk for distress, and we have to keep our eyes open to focus on them. Those are the people who are either isolated because they are COVID positive, those who are quarantined and can't see their family. There are vulnerable populations like the migrant laborers who not even had food and water in this hot environment. There are elderly people and people with comorbidities who without are scared of stepping out of the house. I know people who haven't stepped out of the house for 4 months because of the fear that if they catch this infection, they're probably not even going to be allowed in the hospital. Anyone above 65 for that matter, or anyone with one or more than one chronic illness, comorbidities. And the people, those who have already encountered a loss, as has Ramesh's family, and most importantly, the healthcare workers. And I think 1st July was Doctor's Day, and I was watching TV that day, and Rajdeep Sardesai for the first time said he never knew that there was such a thing as a Doctor's Day, but he also went on to say that this is probably a healthcare workers' day. So the nurses, the ward boys and the ladies, and the lab technicians who are all in the background and working as hard to save patients' life are now being recognized as healthcare professionals and not just doctors. So at least that is something which is positive for me that has come out from here. And could you go to the next slide? So, okay. This is a spectrum of how a person is healthy. They start becoming ill, they become reacting, they're injured, and then they finally fall ill. Chitra, would you like to elaborate on this slide?
Speak on it. So if you look at this, you can see how a person, and this could be any one of us or any one of the patient or the family member. So we think that we are normal, that is the green part. We have normal mood fluctuations, we have, when we try coping, we have more or less good sleep patterns, we are active, we are socially active. So even if something happens, we actually cope with it, and then we get on with life. But when there is something happening around us, then we start reacting to what is around us, and that what is around us become what is within us also. It starts influencing what is within us. So our normal mood fluctuations, or what happens normally in terms of sleep or in terms of activity, becomes more. We become irritable, we could have trouble in sleeping, we could have physical symptoms, we could have decreased activity, we could start using a bit more of alcohol or something. And then when that becomes more, we are still not able to cope. It leads to a state of almost being injured. And then the emotions become more. See, it becomes anger, anxiety, the sadness becomes pervasive, there is increased physical symptoms, there is disturbed sleep, nightmares, there could be increased alcohol use, and finally, if that is also not controlled, you can see that we end up in an illness state where you have angry outbursts, aggression, panic attacks, and somebody mentioned about depression and suicidal thoughts. So when there is suicidal thoughts, we should understand that it is actually an illness state, and it is not normal for someone to hint that they want to end their life or they're fed up with their life. That is an indication that you have to explore. Similarly, for everything, if you look into all these aspects, like for substance use, you could get into acute intoxication or withdrawal. You could just withdraw from people, or you could have constant fatigue and aches. And sleep can be completely disrupted as well. Charu, back to you.
So this slide has a lot of information and meaning for me, because while it tells us how we move from health to illness stage, it also tells us how our emotions are affected at different points, how our cognitive functions are affected, how our activities of daily living or our work life affected, and how our coping strategies become from being positive to become negative. I want to just mention this thing that came up in the chat, which is addressed to Chitra, that within the list of healthcare workers,
I'm just answering that, Charu.
Okay, okay. So today we are going to talk about what all the healthcare workers are experiencing, and there's plenty coming up. Can we have the next slide, Arun? So, okay, so like we said, Dr. Dinesh had mentioned that distress is felt in the psychological realm. It's felt in the heart or in the mind, man mein. So, and the impact, if you look at how we define, how we look at as a person, that they have a physical body, have emotions, they are social beings, and they have a spiritual component also. So similarly, the distress can manifest in all these realms. uh, the distress can manifest as emotional, physical, or behavioral dysfunctioning. And one more most important thing is that people may have pre-existing symptoms, and when distress sets in, these pre-existing symptoms tend to become worse. For example, you just take hypertension. If someone has hypertension and then they learn they have COVID-19, they're probably their blood pressures are going to go up. If they're diabetic, their blood glucose levels are going to be not well controlled. And the thing is that we, in this COVID-19 situation, have had to learn many new skills, like you learned the communication skills, and we have to learn more knowledge to equip ourselves to help our patients, and hopefully these will also help you in the future. But what are the red flag signs? What are the dangerous signs that I and you should be able to identify and then refer to a specialist, refer to a psychiatrist or a psychologist? So someone who is agitated, confused, disoriented, is going into substance abuse at dangerous levels, is having hallucinations or delusions, and suicidal ideation. I think Smriti wanted you to say something specific about this.
I think in this, it's also important that when we talk about physical symptoms in the middle column, these are actually expressions of the psychological distress. We are not talking about the increased, the tummy aches or the multiple aches and pains. They are not part of the COVID illness, but more due to the distress. So we should understand that even psychological or emotional distress can be expressed as physical symptoms, especially anxiety. People can actually come up with saying that they are very tired, they have headaches, they have body pain. So we should not just minimize it to just a physical symptom, but understand that there is an emotional symptom beneath. And of course, the red flag signs that Charu said, we have to be very, very alert to these things. Back to you, Charu.
Arun, can we have the next slide? So we have understood that distress is a psychological feeling and is manifest in various different ways. But how do we explore? What tools can we use to explore a person's level of distress or where the distress is coming from? And so this acronym NURSE protocol is a tool. So there are some examples which are mentioned here for you to use as cues. Name or mirror the emotion. So if you feel that someone is angry, say that I can see that you are very angry. It seems to me that you're angry. I feel that you are in a lot of distress and unable to cope. We need to understand the emotion. Some people say that I can only try and imagine how stressful this might be. I would like to quote Dr. Rajgopal here. I once said, I can imagine how hard this must be. And he told me that the patient had answered back, no, you can't imagine how it feels for me because you're not in my position. So we can also say, I cannot even begin to imagine what you're going through. So this is again a communication skill tool which sometimes you may find useful. We need to respect that the patients and caregivers are going through a lot of distress at this point, and we need to convey to them that we are there for them. We are there to listen to them, and we are there to do the best possible that we can in that situation. So, so support. Is there some, what has helped you previously when you had a difficult situation? Is there someone who you go to when you're in distress, when you go to have a chat with? Can you contact them now? And we explore the emotions further, and we ask them, can you tell me more about what's bothering you? Trying to find the other emotions behind the emotion that they are expressing. So they may seem angry, but the anger may be coming from a place of fear. So we need to explore the emotion. Can we move to the next slide? So coming back to the clinical narrative, we are going back to the healthcare professionals. So whoever was concerned, that we always tend to put ourselves last. So the doctors in the team has been asked to vacate his flat, and his neighbor shoos him away when he actually dropped in to pick up stuff. In the midst of the ICU or the isolation ward, the physician gets irritated and he snaps at the nurse. And the nurse, we have this very severe hierarchy between doctors and nurses, which I find very abnormal and inappropriate. But the nurse becomes anxious as to, is she doing something right or wrong? If she goes and says something to Ramesh's family, would the doctor get upset? And the nurse sometimes breaks down that whatever I try to do, it doesn't seem to help anyone. So I would like you to look at what are the specific issues in this pandemic that you as healthcare team are experiencing, and what could be the strategies that you as a team could do to cope with this better. So we take a minute to get some input in the chat box. Smriti has said respect has to be conveyed through body language and behavior. Very true. Yeah, saying I respect you, but looking at your wristwatch is not a very good non-verbal way to display to them that we are there with them. So, are we getting
No.
anything more? No?
No. No response as of now. Can we hear some response in the chat
Now
box?
the faculty would like to add something here.
Yeah, any experiences that anybody has in terms of how people are treating the team, or or patients or family that when they are COVID-19. There are specific issues which COVID-19 has actually brought up, isn't it? Like somebody in this chat initially told me that the healthcare workers actually, Tasneem Azad, when you said that, there is, you said that healthcare workers also go through a lot. Can you mention what you had in mind, Tasneem, so that we understand?
So we have a response here, so where they feel isolated, they feel at risk of contamination, and on top of that, society sees us as a source of contamination.
Absolutely. And Sonali says that we are scared to have them around. Yeah.
Oh, and we have seen through various social media and on the TV that whether it's North India, it's South India, at various places, healthcare professionals have been chased away because they were thought to be bringing the coronavirus into their environment.
It can be very subtle also, Charu, because I feel lately that I've started working, people are not actually dropping in much into my flat. Earlier, during the lockdown, I used to get a lot of, people used to come and ask if I needed anything. In the last 1.5 months, I come back from work and I see the doors closed, I don't think it's directed against me, but there is a fear because I'm coming from the hospital. So the stigma, that is one of the specific issue that COVID-19 has brought, isn't it?
Yeah.
There are issues of unresolved conflicts,
Yeah.
which results in venting out on the co-workers sometimes.
Can you have the next slide? Dr. Dinesh?
Just taking on what Sonali has mentioned, what Shilpa has mentioned, there's the kind of fear that is now developed against the healthcare workers and also against the patients or their relatives is some kind of stigma that they are experiencing. Okay? And this adds to the overall distress of everyone. So in picture, do you find anything related to stigma in this picture?
Came in the Indian Express, I think, very focused on a doctor labeling, stereotyping, and discriminating.
Yeah.
Yeah,
So
the lift
someone has
is labeled.
identified. Lift is labeled as Corona lift. Now lift has got nothing to do with Corona. So even the choice of words that we use for maintaining the various precautions that are to be taken, they will also communicate some certain level of stigma at various levels. So that we have to be very mindful to the fact that stigma does exist. And sometimes our very simple acts might lead to this increase in the stigma. So we have to be very thoughtful about that.
Yeah, I agree, Dinesh. I think the main things that because Charu just was also saying what strategies can be used to mitigate, or bring this, stigma will be there, but then giving in correct information, the right information, what people actually need, and not really bombarding them with unnecessary information in a very simple language, not using terms like, like Dinesh said, like these, like Corona lift, or, people, victim, Corona victim. These were the words that people were using. So we have to be very careful also in using appropriate words, like saying that a person with Corona, COVID infection, or COVID affected families, or COVID affected person, rather than calling them victims. And another term I see often now is warrior. The healthcare worker is kind of burdened with the term as warrior, and we are expected to be warriors, like as if we are going to a war. And then this is an unconscious pressure on us that we have to do certain things to maintain that, kind of altruistic tendency. And some people really don't want to take that risk. So we should really understand that. So these are all the words that the media, the whole society brings up. It's a natural process, but we should understand as a system and start looking into it. NIMHANS, the National Institute of Mental Health and Neurosciences, actually brought out a lot of videos educating the public about COVID-19 in many languages. They have brought about in English and in Hindi, and you should access that. There's a lot of message going out to the public from healthcare workers that stigma should be managed well. We might not be able to completely abolish it, but we should certainly address it. Charu?
Even before this COVID-19 pandemic had struck, doctors and the healthcare workers have not had an easy life. We all remember a young surgeon in Bengal who was beaten on his head because an 82-year-old man developed a stroke and he died. And his family members beat him up, and that doctor can no longer hope to become a neurosurgeon. So even in normal circumstances, healthcare professionals are not looked on as favorably, and this COVID-19 has just made things worse. And not only for healthcare workers, also for the family members, because just to share an experience, we have a family here in the society where I stay, where 4 people had gone for a wedding. 3 people turned out to be COVID positive, and the 4th was supposed to be in quarantine. So I put in a WhatsApp group that if they require groceries, medicines, or cooked meals, we can give it to them, and they can reach out and ask for help. And I got very indignant responses saying that 4th person is in quarantine. I said, well, if Corona is not going to kill them, hunger should. And after that, obviously we can just go leave the stuff in front of their door and they can pick it up. So people are just extremely paranoid at this point of time. Can you have the next slide, Arun? So elaborating, this is, I think, something that all of us feel. There are certain terminologies which are given here. You have expressed these as aspects of distress that you have gone through. So, but let's elaborate and see. Moral distress. What is moral distress? Doctors and nurses have had certain training, and there are certain moral beliefs or ethical values that we tend to follow. And in these circumstances, sometimes there is a clash between what we are expected to do or what we want to do, but what the facilities are available and how do we choose. For example, if a 75-year-old man comes who has no comorbidities, but a 45-year-old man comes with asthma and hypertension, and I have only one isolation bed, who do I give it to? And if I refuse it to one and the other person ends up dying, I end up with more guilt. So that's moral distress linked with guilt. Then there is compassion fatigue. Say whatever you want to. People say, as Dr. Chitra has said, that healthcare workers are being called warriors and they're being called gods and all these things. But, and when we look after people who are patients, we develop a relationship with them. For however long the duration of our interaction is. And when you care for them, you give a part of yourself to them. And to continuously look after someone with dedication, giving a part of your heart to them, sometimes ends up as a big burden on yourself. So I heard someone say that your compassion is incomplete if you're not compassionate towards yourself. So we need to recognize that compassion fatigue is a thing. And here I think the role of team members become very important. Somebody can keep an eye on a particular person and see, are they not behaving their usual self? Are they running out of energy, running out of steam for their work? And then there's this third term called burnout stress. Invariably, as compassion fatigue is relationship between a healthcare worker and the patient, burnout is because of the workplace environment. And everybody faces that, doctors and nurses. Nurses, because their value is not recognized, and in many places they don't get appropriate salaries. And doctors are struggling to tell the management that we require more ventilators, we require more beds. And in this period, everybody has had to work very hard, but hospitals have not are not earning money, and lots of doctors and nurses have not received their pay. And so that can be a big reason for burnout. Can we have the next slide? So burnout has these three components. One is emotional exhaustion, which is fed up of fighting the system. You tend to feel a low personal accomplishment. You are unable to do your work. You're unable to help people because of the restrictions that the work environment has put around you. You tend to then develop a sense of depersonalization, where earlier you had a relationship with the patient where you gave a part of yourself to them from compassion. But here now that patient, Ramesh, just becomes bed number 98. So a combination of these is what is burnout. And we need to take care of ourselves at a stage much before we reach the stage of burnout. And here again, I would stress that the importance of team is very important. I would also want to point out, we have discussed moral injury, compassion fatigue, burnout. Where does depression come in? You know, someone may say this emotional exhaustion, or I'm worthless, I'm useless, I'm hopeless, I'm not achieving anything. These are also things that people who are depressed say, but burnout and depression are completely different things. Burnout cannot be treated with medication, whereas depression is a clinical condition and may require the help of a psychiatrist to give the medication and a psychologist to help them through their journey. So we need to differentiate distress from these four things. Can I have the next slide? Okay. We are again here on burnout and how do we look after ourselves. When we talk, I think this self-care has also been covered by someone in
Dr.
the
Biju
last
covered
4
it.
days. Dr. Biju covered it, but let's do a very quick recap. How do you do self-care? When you go back home, everyone says, do something that gives you joy. I remember Dr. Rajam asking people, what helped them to unwind once they went home? And some people said yoga, meditation, music, reading a book, dancing, things like that. So looking after yourself is very important. In the work environment, recognizing that your team, if it is healthy, can actually be very supportive of each other. If the day has been very difficult, people can actually, when the shift ends, for 10 minutes, they can take a break, share a cup of tea. Someone can let their tears flow and say, I'm fed up. I'm unable to cope. I lost this gentleman who I had been caring for such a long time. A doctor can apologize to a nurse and say, I'm very sorry. I just had a very difficult interaction with the patient's family, and that stress all came out as an impulsive uh, outburst and as anger towards you. I did not mean it. I'm very sorry. And so this period of debriefing can also help people recover. And like I said, in these dark times, we have to look for something positive. And someone in the last few days has also told me that people are turning more inward and they're realizing the value of relationships. Chetan Bhagat, I think, had once said that nobody is going to remember how good a presentation you did when you're dying, but people, your family and your friends are going to be on your bedside. So I think COVID-19 has taught us the value of relationships and spending more time with our loved ones. Can I have the next slide?
So Charu, people have shared what they would like to
Yes,
achieve this
Dr.
kind of
Dinesh, could you
work
summarize
balance.
please for me?
Yeah, so they want to play guitar, listen to some music, sitting silently, watching cartoons.
Yes. Tom and Jerry, I love that.
Then trying to find their own space. Okay. There's a whole lot of activities that people have mentioned. So we should never forget that even in this difficult time when you are short of time, so these activities will help us to use that time in very quality way, and they'll go a long way in self-care.
I agree, Dr. Dinesh. I think the importance is that when you remember these things, it's also to reflect whether you're actually doing it. Are you doing it for yourself? Are you taking time in between in this overwhelmed situation that we are, and doing these things to bring in some sort of composure, some sort of stability, some sort of happiness and joy to yourself? So that's very important that you use these strategies, which is important for you to bring in those. And also, probably like Charu said, I think at the work environment, it is very important that we have certain, if you go to the ebook, there are specific strategies that are listed out in the burnout section where you have the teamwork, where you build emotional, social connectedness, and also how to maintain, a blend of the work And life, even when you're working, the team leader has to ask his team members, how are you doing today? What's happening with your family? How's your child? Rather than just focus on the patient and the medications, also to talk about other things which is important to that person, to bring in sense of meaning.
Yeah, I remember Dr. Rajgopal. My son was 2 years old when I moved to Kerala, and I got an opportunity to work with Dr. Rajgopal, and he never used to call me Charu. He used to say, how is Vishwanath's mother doing today? So that meant, yes, playing with my son. That was one of my favorite things too. And now my son is 19, and I'm now looking for a dog and fighting with my husband to get me a pet. Arun, can we move on? So coming back to our clinical narrative, and how do we look at this stress? So the nurse breaks down, says, whatever I do doesn't seem to help anyone. It doesn't help the patient, it doesn't help the family, even the doctor's irritated with me. My life is worthless. I have no hope. How am I going to deal with all this? What's the purpose of my life? What is the purpose of my existence? What do you think she is experiencing? Where is she experiencing this?
There's a response, depression.
Sharon,
Would
there is
others like to
something mentioned as depression.
So what do others think?
Burnout.
Burnout. Okay.
I'm glad that both these things have come out, because the symptoms or the symptom complex is very similar. Existential crisis.
Yeah, this answer we will not consider.
Yes. So these are something which are very finely linked to each other. But I think for us, it is enough that we understand that these concepts exist. And when we don't know what to do, we ask for help. We don't become a smaller person.
Shilpa has said spiritual distress. I think very important. If you look into the, can we go to the next slide?
Okay.
Chitra, would you like to?
Yeah, I think very important, Shilpa, and I think that's what Dr. Param also meant, and probably everyone who meant, whether it is, that is the probably the challenge that also distress, a term like distress brings. And like Charu said before, that when you have emotional distress, there's so much overlapping also. You could have depression, burnout as well, then spiritual. So we need to know, we need to use all these domains to understand. And like Moira is saying earlier, hopelessness was also said. This can be also spiritual. So spiritual distress is something where it addresses what the person has in terms of meaning and purpose, or connectedness within themselves, to oneself, to others, to the universe, to God. It could be anything. It is actually very subjective, but it is very unique to a person. Each person has their own way of making sense of what brings meaning and purpose to their life. It is quite complex also, because it cannot be teased out as one single factor. It is a mix of factor, like this picture actually says. It's very personal as well. And for for a patient, it could be, whether he's, the acceptance, or the affirmation. It could be about asking for forgiveness, when he's going to die, when it's the end of his time, to feel that I'm being forgiven. What is the meaning of my life? Did I do good for others? Is God punishing me, or when am I going to meet God? These are the questions that goes through a patient's mind. Whereas the caregivers of the family would be feeling, a lot of distress in terms of the hope, which is realistic or unrealistic, and the whole helplessness and hopelessness that they have. There would be also, a blurring of the meaning in terms of their clarity of their role. And for us as professionals, I think, for us, our own sets of beliefs, what is the meaning of, like we had discussed in terms of connected to burnout, what is the meaning of our own, role in this? How to prioritize, what to do for this patient when we are also going through struggling. So this is a very complex, but probably a universal phenomenon. All of us have these, domains in our life, and it does not necessarily be always connected to religion and faith. Religion and faith is one of the ways that people pursue spirituality. So we should take care that we do not impose our own sets of values on people when they have such kind of distress.
Thank you, Chitra. That was beautifully put. Harun, can you go on to the next slide? Okay. So,
Can we skip this?
you want to continue, Chitra?
Yeah, I want to continue because I think we'll go to the algorithm and if we can come back to this.
Okay,
Because,
so
Next slide
okay.
is algorithm.
Next
Arun,
is
next slide,
algorithm.
please.
I'll just talk about the distress thermometer. It first came out for cancer patients, but it has been used extensively in other areas also. Dr. Chitra and I had, and one of our colleagues, Dr. Sunita Daniel, who's a faculty here, we had actually done a project or a study using the distress thermometer for patients with COPD. So distress thermometer is something very similar like your numerical pain rating scale 0 to 10. And if we go back to this slide, can you go? So if you can see on the right side, it might be slightly difficult to read, but the distress can be because of practical issues, family problems, emotional problems, spiritual issues, and or for physical problems. So the distress can be caused by all these, and distress can be manifested in all these domains also. Can we go to the algorithm? Next slide. Smriti wanted Chitra to explain this to all of us.
Yeah. So this is a simple, very simple algorithm or a pathway that you could use. I can see Shilpa asking how do you use it. This is how you use it. Shilpa, you can see this,
Yes.
and others, you can see the distress thermometer lying beneath from the green to the red, and it mirrors the journey that you remember the other green to red slides we had where people go through the journey of their emotions which can go to an illness state. So it reflects the same. So when you have no distress, people usually score 0. And when it is extreme distress, it is like 8, 9 or 10. And 10 is the maximum in this scale that you can measure. And this usually distress is measured for the last 1 week. So that means that we have to routinely screen for distress. So if you look at the algorithms, you can see that it starts with the open questions. You're calling, introducing, especially for COVID, you check where they are and you say where you are, and then using your communication skills of reflective listening, open-ended questioning, empathizing, you elicit the symptoms that we had mentioned in those. You remember that slide where in columns. And then if you are using the screening tool, you see that with the tool and the scores, you can actually, they come into 3 columns. And when they are in the green section, that is when it's less than 4, usually people can be helped with psychosocial interventions. That is, you can educate them about the distress, educate them about COVID-19, clear all the misconceptions, misunderstandings also, address stress in terms of improving their support. That means you have to help them cope. So you're improving their coping competence, help them to calm if they are by relaxation. And there is a lot of this. There is a section in the ebook that you can go through. You help in normalizing the emotional reactions, maintaining realistic hope, which is very important by using support systems like, you know, your family, the community, especially values and faith, like we mentioned earlier. But I think it's also important that we try to promote as much as daily activities possible, especially the sleep. And sleep hygiene is given in the ebook. You can go through the measures of sleep hygiene. But if the distress is more than 4, and they are not able to cope with this specific measures, along with these measures, you may have to start medications. So the usual medications we start for either depression or anxiety is the selective serotonin reuptake inhibitors like escitalopram or sertraline. The doses are given, like escitalopram you start with 5 milligram and go up to 20 milligram, and sertraline you can start from 25 milligram and go up to 150 milligram per day. And if there is acute anxiety and acute panic attack, you should add benzo. Or if there is sleep disturbance, which the person is not able to really manage with sleep hygiene, you can add a small dose of lorazepam. But after 2 weeks or so, you taper and stop it, and you actually give the SSRIs for 3 weeks up to 6 months, so that the episode of depression and anxiety gets better. And then you go to the right end where you remember the red flag signs. So when there is no improvement with both these and they have a worsening of symptoms like agitation, confusion, substance use is increasing, they have psychotic features like hallucinations or delusions, and most importantly, if they are hinting some frustration, some thoughts of ending their life, refer them to a specialist. When I'm talking about this, I just want you all to reflect on, if a person is hinting something about frustration or saying that I'm fed up, do you actually ask about suicide? How do you address suicide in your settings with your patients? Have you tried doing that? Can you put it in the chat? So I'm going to the chat also, Charu.
Yeah, sure.
Meanwhile, I want our people to just say how they address suicide now in their setting by themselves. We should discuss that also. So, having this.
Yeah, this is distress people. We had started with this, that I actually went online to see what is the exact Hindi meaning of distress, and things like pida, sankat,
Yeah.
all these came up, and for me, it was important uh, that we talk about.
Yeah.
Uh,
So I hope, Shilpa,
Focus
this
on.
makes sense to you in terms of how to use the distress thermometer. And I'm sure the distress thermometer must be translated into Hindi by some group in India. If you Google for, evidence, you will get it. And you use the culturally appropriate word like Pida, I agree. So Dr. Uma Shankari says no, but they say they feel like dying from there on. So you don't address suicide because you are scared whether they would say that they feel like dying. Okay. Anybody else who want to talk about suicide? How do you address? Do you address at all? Do you ask people, or is there a helplessness? Like, if I ask, because there's a common tendency or a feeling that. Shilpa, do you ask? Can you say how do you ask, and what kind of questions do you ask them? Very good that you are asking them. So there is a tendency to feel that we actually, if we ask about suicide, then they will end up committing suicide. But it's the evidence shows the other ways around. If you start talking about it, you can actually prevent suicide. कभी लगता है कि जीवन क्यों है? Yeah. Do you feel frustrated with life? Do you feel fed up with life? Have you ever thought of doing something to yourself? And then from there on, go on. So you cannot ask directly in one question, but you build up the rapport, build up, and then ask. Shilpa, we'll go through the questions again. Charu, I'm handing it over to you.
Yeah, I think we are running short of time. I just, something came in my mind when Dr. Chitra was explaining this. When we were talking about Ramesh, when things start going downhill for a patient with COVID-19, they go downhill really fast, and we don't have perhaps time to address distress using medication. But we need to remember that the family and their healthcare workers may suffer from distress and depression and may require medication. Can we have the next slide? Arun? Okay, so Dr. Chitra has already summarized this, that if someone is in distress, how do we support them? We normalize their feelings. We don't dismiss them as being insignificant, but we tell them that it is very common in this situation to experience that. We give some education. Sometimes just being able to talk to someone would help. Can we move on?
I think,
Next
Charu,
slide.
you go on. I'll just say that I think ventilation and validation is very important. That is
Yeah.
a non-judgmental, non-confrontational listening to people when they say about what they are going through. That is very important. Next slide, please.
Yeah. Smriti, are you around?
I think Smriti wanted to talk about trauma as well. So,
yes,
I'm here.
Yeah.
right.
Do you want to talk about it?
Yes. So very quickly, I know we're being mindful of the time. While we talk about anxiety, fear, and grief, it's also important to remember that some of the things that we as healthcare workers, as well as the people that we are working or caring for, are experiencing trauma, and that is of a slightly different texture and quality than just anxiety. I mean, although anxiety can be debilitating, I know. And trauma, the definition of trauma is really it's exposure it results from exposure to non-normative experiences. Now, what we are all experiencing today is not normal. I mean, it's not something we planned for. It's not something we imagined. And although we talk about the new normal, nothing about how everything is working around us is normal. We're adapting on a regular basis. And when this sort of prolonged exposure to that sort of stimulus happens, there is a profound dysregulation of our nervous system. And that is something that I think we're seeing in a lot of people around us. And it can cause a sense of extreme fear in some people because of the sheer uncertainty and the unpredictability of everything that's happening around us. And all of these things that we have an assumption about the world, how the world works, how things should be, what is the sequential, what are sequential events, the plans we might have for our lives, all of those frameworks are quite shattered. So this is one kind of sequelae that we see in experience of trauma. Arun, next slide, please. And like we've talked about on several occasions now, there are different manifestations, just like there's different manifestations of distress and grief and things like that. Trauma also manifests in different ways, like acute anxiety, sense of numbness, increased substance use. So there are overlaps with other manifestations of distress. So we can't really say that this is how trauma manifests, this is how anxiety manifests. There are a lot of interlocking themes, which also makes it very difficult to disentangle, the different diagnoses that might be emerging. And loss of meaning, demoralization, we see this also in burnout, like it was pointed out. So this is just to give you a snapshot of some of the ways in which trauma manifests. Next slide, please. And responding to trauma it's such an intense experience. But in the settings that you are currently in, what can we do in terms of psychological first aid? Addressing trauma, we might need professional help in the long run, etc. But in the moment, there are certain exercises that can be done in your own settings. One of them is a grounding exercise, which is called interoception. And interoception is basically the feeling the interior of your body, becoming aware of your own body, what might be going on within it, identifying and naming certain discomforts and distresses. So that in itself becomes a little bit of a grounding exercise. There's an orientation exercise, which is more outward looking, where when you feel like things are getting out of control, it's always good to look for something normal, a normal aspect. It could be something small and routine. It could be the fact that at 11 o'clock every day, you get yourself a cup of tea. So noticing and anchoring on certain normal aspects is also a very grounding exercise. And providing support through listening, witnessing, and offering compassion. Not all of us will be able to give psychological interventions, but just this act of listening and witnessing and offering compassion often is very cathartic to the person who's experiencing trauma. And I cannot overstate how important it is for peers to share experiences and acknowledge our common humanity. So this is why a forum like this, where we as healthcare workers and providers from different settings come together and we share our experiences. And I've seen the chat box so full of shared experiences that you identify with what is happening. So you feel less alone. So that is also a way of diminishing trauma. Next slide, please. And this is just a hat tip to the fact that these are the various ways in which healthcare workers might be experiencing distress and trauma. Vicarious suffering refers to, suffering yourself because you're witnessing so much suffering. When you see somebody going through a lot of suffering, being human, being in the compassionate caring services, it does have a response in us, which is also a kind of suffering that we experience. Disenfranchised grief refers to grief that is not socially acceptable for various reasons. It could be because of the relationship not being socially acceptable, or it could be the fact that as a professional healthcare provider, you are expected to be stoic. You're expected to be, not too emotionally invested in your patients. But so often when you feel grief, it's sometimes looked down upon to grieve over the loss of a patient, and that could be disenfranchised grief. So that is something that we go through at a time like this. Grief over our own relationships. Some of us are locked down away from our loved ones. Some have lost loved ones. Some relationships have changed, so there is grief about that. Multiple losses, not just in terms of people and patients and people known to us, but also the loss of a future plan. The fact that your child is going to go to college this year and has had to miss out on that opportunity, the loss of certain opportunities in your career, the loss of so many different things. Role conflict that I think a lot of us might be experiencing at the moment, your role in your home and your family versus your role in the healthcare settings, the conflict that comes with that, the role within your team that you might be feeling some conflict over, and guilt over many things, guilt over possibly endangering your own family, guilt of not being able to help the patients and their families enough, guilt over, I mean, there are several reasons. It's a very damaging emotion, but these are some of the things that we're just acknowledging that healthcare workers could be going through at this point.
Can we go with Smriti?
Yes.
Because I think we don't, it's time,
yes.
I think it's hardly 4 minutes.
Yes, please. Arun, next slide, please. And Chitra, I'm going to just invite you, because you put the slide together so beautifully, that what it means at this point for all of us to really connect with meaning.
I think when we talked about what actually the situation is about, how we bring in meaning into our life, how we connect, maintain connectedness to what brings meaning into our life, what brings purpose into our life. And then it's about building yourself inwardly, connecting inward, looking into the resources within yourself, your own resilience, and you can see these pile of pebbles or stones, which are actually in awkwardly placed, but they're standing together, isn't it? And all of us are like this, we build up, we struggle, and we, kind of dig up our own resources, and we face the challenges. Prayers and collecting upwards to God, in whatever way you want, praying, reaching out to Him or the whole universe, and also outwards to nature, to the sun, to the birds, to the, the trees, the colors, the joy around us. All these brings in meaning. And it's very important that we continue to do this to maintain, to sustain this kind of a spirit in this COVID situation. The next slide, please. So I've just summarized saying that mental health issues are significant in the context of COVID. Identifying, assessment, and management can be carried out by the primary care team. You do not need a full-fledged specialist team to manage at the primary care level. Addressing spiritual needs is absolutely essential to deliver total care. And I would recommend, and I would always request all of you to go through the supporting documents and the algorithms in the ebook, because it will really help you to follow this and use in routine practice. Not only during COVID, it will help you address psychological distress in your routine practice in the future too. Next slide, please, Arun. So these are the further resources and for training, which you can see. And the next slide. Again, you have some more resources. And next slide. Thanks to the contributors for the ebook, PalliCovid and PalliMedia team. And next slide is your feedback on the Google form. I request all of you to give a feedback. Thank you so much. And we need some kind of, Smriti, you want to take over?
Yes, thank you, Chitra. So thank you. And I have to admit that I prepped for this session and tech failed, and I felt a strange amount of distress over that. But great teamwork and co-facilitators and faculty members coming in. So an emergency was handled in my books. So it all worked out well. So thank you all very much for being patient through it all. And thank you, Moira, Chitra, Dinesh and Charu for just beautifully taking it over. We're now at the end of an incredible 5 days. And this has been a learning opportunity for all of us, even those who've been, putting the ebook together or the ones who are coordinating and things like that. And we would love to hear from you. How useful you found these 5 sessions, if you've been able to incorporate some of these learnings into your practice already, or you see the relevance of it going forward. We would really love to hear from you about all that. We did want to have a discussion with everybody.
Yeah, I would actually like all of you to just write at least one point which you feel about the sessions, like one statement or one word that you feel about the sessions. How, I mean, in terms of supported. Good, thanks, Sonali. And anybody else to just great sessions. Thank you. So we hope that these have been really useful, and we need your feedback because we need to improve and improvise further to what we are doing now. So please, yeah. Moira says, can you write one word or statement that summarizes what you feel about the session? Yes.
Vani is saying inspiring and informative, Chitra. Lovely.
Okay.
And Vani, we send our particular greetings to you all in Mizoram.
Empowered, says Shilpa, to provide better care. That's even personally, that's absolutely a great feedback, Shilpa. Thanks a lot. The whole session, Dr. Raji says, clearly told us how a distressful situation like tech failure can be effectively managed. So this